Welcome to the second part of the first basic exam practice test review. We'll continue on with more questions. Our next question had to do with cauda equina syndrome with neuraxial anesthesia versus transient neurologic symptoms. So, in general, cauda equina syndrome after neuraxial anesthesia is incredibly rare. And this is defined by having both sensory and motor disturbances after neuraxial. Years ago, it was a popular practice to place spinal catheters and give small doses of continuous local anesthetic. But there was a spike in cauda equina syndrome, and this was thought to be mostly due to direct toxicity of the nerves. Something else that was described a little bit later in the early 2000s is called transient neurologic symptoms, and this is different from cauda equina syndrome because it's a sensory problem without any motor disturbances. Classically, it's described as posterior thigh pain. The patients who are in the lithotomy position after spinal tend to get this most commonly. It's most commonly seen after using lidocaine for a spinal, which is another reason that we tend to use only bupivacaine and not lidocaine. The good thing about TNS is that it is self-limiting. The pain symptoms tend to resolve in about a week or so, and patients who are obese are also more prone to this. There's a question about asthma exacerbation treatments. So in the question, the patient was shown to have both hypoxemia while receiving increased FiO2. Many of you chose that Heliox would be a good option for this patient, but given that Heliox is 30% oxygen plus 70% helium, this would take away the increased FiO2 that the patient was having, and you would assume that the patient would then become more hypoxemic. The purpose of Heliox is to reduce the density of the gas being given. What this does is it allows for more laminar flow around an obstruction, not necessarily through a narrowed airway. Laminar flow anyway is more likely in narrowed airways, so giving a gas that further allows for laminar flow wouldn't necessarily help that much. Asthma exacerbation treatments include inhaled beta agonists such as albuterol, inhaled anticholinergics such as ipratropium, glucocorticoids, which take a little bit longer to work but are still a part of the mainstay of treatment, and other agents that are more down the line that can be used are IV magnesium, as well as anesthetic agents if a patient in status asthmaticus cannot be treated with any of the above. Oftentimes they're put under general anesthesia and allowed to breathe inhalational anesthetic agents, which dilates bronchial smooth muscle. This question has to do with the mechanism for hypoxemia when atelectasis occurs. So what atelectasis is collapsed alveoli, which tends to happen more frequently under general anesthesia. What happens is that alveoli are collapsed. They continue to be perfused, but they're not ventilated. This essentially leads to a right to left shunt, meaning that blood flows through the lungs but does not pick up oxygen, which is known as just as shunt. So other causes of hypoxemia are VQ mismatch, which is often another way to describe dead space, where lung is ventilated but not perfused. And that's the opposite of what happens during atelectasis. Other pathology that results in VQ mismatch is pulmonary emboli. The lungs are still ventilated, but no blood is flowing through it. And also COPD and other diseases where lungs are hyperinflated and perfusion is not increased. Diffusion impairment can result in hypoxemia. Diseases such as pulmonary fibrosis and other vascular disease. And then, of course, hypoventilation can result in hypoxemia if to a certain degree. It's a very common topic tested on the basic exam, cerebral autoregulation with changes in blood pressure. So with an intact blood-brain barrier, blood flow is maintained between mean arterial pressures of 60 to 160. And you can see on this graph over here that this is the case. As pressure drops below mean arterial pressure of 60, flow tends to drop off. And as blood pressure increases above mean arterial pressure of 160, flow tends to increase. Now, this is done with relaxing and constricting of cerebral blood vessels. So with falling pressures, cerebral vessels vasodilate. They get bigger and bigger and bigger, as you can see on the top of this picture, until that 60 area, when they cannot dilate any further. And then as pressure falls, flow tends to fall. The opposite is true with rising pressures. So as pressure increases toward 160 mean, cerebral blood vessels constrict, and then there comes a point when they can't constrict any further, and flow tends to increase at pressures beyond that 160 mark. Our next question topic is hyperventilation and CSF bicarbonate. So this is a bit of a tricky concept to wrap your head around, but if you take it step by step, it's not too complicated. So this really gets into the nuts and bolts of why we hyperventilate patients in the ICU after a head injury, and also in the neuroanesthesia room when they're operating within the cranium. So what happens when one hyperventilates a patient to a CO2 of 25? So several things happen initially. So first of all, hyperventilation will create a local alkalosis by blowing off CO2. CO2, you have to remember, is easily diffusible across the blood-brain barrier because it's a very small, non-charged molecule. This is in contrast to ions like bicarb that are charged and much larger. So these ions take longer to move across the blood-brain barrier. So initially when we hyperventilate someone, we blow off CO2, we create this alkalosis, and it takes about 6 to 24 hours for the bicarb to catch up, for the bicarb to leave the CSF. At this point, vasoconstriction returns the cerebral blood flow to baseline. Now, if hyperventilation is stopped at this point, the opposite tends to happen. CO2 goes back up, is able to cross into the blood-brain barrier, and a local acidosis is created. Now, bicarb follows this in order to maintain the acid-base balance, but it takes time to follow. So in this first 24-hour period after stopping hyperventilation, you can actually see an increase in cerebral blood flow higher than baseline, which can be detrimental. And the lesson to be learned is that hyperventilation is really a short-term fix and for short-term decrease in cerebral blood flow, which is perfect for in the operating room, but perhaps not so great for long-term management in the ICU. All right, our next question is in reference to cardiac toxicity with bupivacaine. So CNS toxicity tends to increase blood pressure, increase heart rate, and increase cardiac output. And this happens because the first thing that tends to happen with local anesthetic toxicity is neurotoxicity and specifically seizures. So cardiac toxicity comes much later, and what happens with bupivacaine is that sodium channels in the heart are blocked and conduction abnormalities take place. This leads to arrhythmias, particularly ventricular arrhythmias, which need to be treated promptly. Now, treatment is with intralipid. This is a picture of what intralipid looks like. It's a milky white fluid. And dosing of intralipid often comes up. So initially, you are to give a dose of 1.5 milliliters per kilogram bolus, and then an infusion of 0.25 to 0.5 milliliters per kilogram per minute as an infusion for up to an hour or as long as cardiac toxicity persists. All right. So this is a somewhat confusing topic that can also cause a great amount of trouble on the exam. So factors that increase inhaled agent uptake from alveoli. So there are two main factors, solubility of the agent as well as cardiac output, that determine how quickly agent is taken up from the alveoli. It's important to remember that the concentration of inhaled agent in the alveoli predicts the concentration of the inhaled agent in the brain. So therefore, the more agent that you have in the alveoli, the more agent you're going to have in the brain. So agents that are more soluble tend to have a slower rate of rise of Fa over Fi, because they tend to be picked up by the blood and carried out of the alveoli, and then the concentration in the alveoli is reduced. So we can see that agents that are less soluble, such as nitrous, tend to have a faster rise of Fa over Fi than agents that are more soluble, such as halothane. Now, high cardiac output also allows more blood flow through the lungs, which thus allows more picking up of agent and carrying it away from the alveoli, slowing the rate of rise of Fa over Fi. So what this says is that cardiac output of 18 has a much slower rate of rise than cardiac output of 2. The other thing to remember is that this effect is more pronounced with the soluble agents. You can see that with the insoluble agents like nitrous, all of these lines are fairly close together. The rate of rise of Fa over Fi is pretty similar, depending on, regardless of the cardiac output. With an agent that is more soluble, the difference is more pronounced. A higher cardiac output is much slower than a lower cardiac output. So here's our bottom line. More soluble agents equals more agent removed from the lung equals slower rate of rise of Fa over Fi. Higher cardiac output equals more agent carried away by fresh blood flow equals slower rate of rise of Fa over Fi. All right, so there are a fair amount of equipment and physics questions on the basic exam. So this question had to do with the characteristics of modern vaporizers. So all the vaporizers that we use are agent-specific, meaning that the vaporizers that vaporize sevoflurane are calibrated quite differently than the vaporizers that are for isoflurane. They are temperature compensated. So what this means is that as liquid becomes a gas, this uses heat and ultimately becomes cooler and decreases the amount of vaporization. So there's a strip called a bimetallic strip within the vaporizer that moves as temperature is altered. This changes the amount of gas flow that goes through the vaporizing chamber and thus maintains vaporizer output. They are variable bypass, so as we turn the dial up, it directs more fresh gas flow through the vaporizing chamber and less through the bypass chamber. They are also flow over. That means that the gas that flows through the vaporizing chamber flows over a reservoir of gas. This is opposed to bubble vaporizers. An example of a bubble vaporizer is the old copper kettle, where fresh gas is actually bubbled through the liquid. So in our modern vaporizers, the fresh gas is not bubbled through the liquid. It flows over the top of it. So this question topic had to do with anesthetics and the liver. It gave a variety of statements and wanted you to pick the one that was true. So, and the true statement was regarding halothane hepatitis. So this really is a thing of the past since we can't use halothane anymore, but they still test you on the idea of what halothane hepatitis is. So it's an immune response to breakdown products and essentially results in necrosis of the liver and has a very high rate of mortality. It's up around 50%. So other things about the liver that are commonly tested is liver metabolism of various inhaled anesthetics. Halothane is extensively metabolized in the liver, or was, and we can contrast that with an agent that we use now, sevoflurane, which has the highest metabolism of the currently available anesthetics, and this is only 5%. Liver blood flow is also commonly tested. All inhaled anesthetics decrease liver blood flow based on vasodilation. Right, there is a question that was commonly missed about what happens with a bolus of thiopental through the IV. So again, a couple of questions back to back on medicines that aren't commonly used but are still tested on. And thiopental is something that was popular before the advent of propofol in the 90s. So thiopental is an extremely alkalemic IV medication. And so this question described it being injected through a quote-unquote IV that was placed on the wrist, which was probably actually an A-line. So what happens with arterial injection is that profound vasoconstriction occurs, crystals can form, and then that leads to thrombosis. This results in ischemia and necrosis, which you can see on the picture to the right here. So what do we do if this does occur? So we can give intra-arterial lidocaine, which helps to dilate the arterial vessel. We should systemically heparinize to help prevent thrombosis formation. Alpha blockers can dilate the arterial system, and also brachial plexus blocks can help to dilate the arterial system by reducing the risk of vasospasm. So those were all options that were on the question. All right, our next topic is propofol dosing with age. So this graph here is a little bit hard to read, but essentially what you can see is that younger age children tend to require higher doses of propofol on a per kilogram basis. Now that's the opposite is true for preterm neonates, which need less propofol. And the reason for this is that they have decreased fat content overall, so the extravascular compartments are much, much smaller. Young children require the highest, and then throughout childhood, this amount decreases with age. All right, so this topic is EEG and etomidate. So the question had to do with how etomidate affects EEG activity. And a couple of important points to remember is that etomidate can actually help with the mapping of seizure foci because it tends to increase EEG activity in these epileptogenic foci. Other medicines such as propofol tend to reduce EEG activity in these areas, but etomidate tends to actually increase epileptogenic seizure foci. So with SSEPs, there's less disruption in latency and amplitude than with propofol. Some cases it can actually increase amplitude. When doing spine procedures, theoretically you could give etomidate to have better mapping, but of course there are downsides to etomidate that we don't have to go through at this moment in time, which is why we don't actually use it. But the bottom line to remember with this topic is that etomidate provides excellent conditions for which to map seizure foci because of the increased EEG activity. All right, so another question about cardiac conduction and the speeds through the various portions of the heart. So the answer to this question was that the AV node has the slowest conduction rate of any part of the conducting system. And this has a physiologic reason. So if you look at the other areas of the conducting system, the area between the SA node and the AV node, the bundle of His, those have relatively rapid rates of conduction, about 1 meter per second. Into the Purkinje system, that actually increases to about 4 meters per second. And then the ventricular muscle itself has conduction speeds of about 1 meter per second. So the AV node has a dramatically slower rate of conduction, and the reason for that is that the heart needs, or the atria need time to empty after the atrial contraction prior to the ventricular contraction. So if the conduction rushed through the heart at a constant rate of speed, the emptying of the atria wouldn't be allowed to fully take place. The heart is such an interesting organ. All right, so here's a question on some topics in statistics. So the definitions of mean, median, and mode often come up. So what is mean? Mean is essentially the average of a set of data. Median is if you listed the data in order from the lowest number to the highest number, it would be the middle number in a set of data. The mode is the most frequent number seen in a set of data. So the question gave you this very graph here and asked you to put in order the from least to greatest, the mean, median, and mode. So in this example, the most common number, the mode, would be the lowest. It's at the peak of this graph here. Median would be somewhere in the middle because you have lots of lower numbers, but then you have some lingering higher numbers. So if you put them in order, median would be a bit higher than the mode, but a bit lower than the mean. And mean would essentially be highest because all of these data points toward the right tend to skew the average in this way. So the mean is closest to the tail, the mode is closest to the peak where the most frequent numbers are, and the median is somewhere in the middle. All right, so this is a really, really important topic to review prior to the basic exam, the ACC/AHA guidelines for non-cardiac surgery. The question that I put in here, I read a couple of times and I felt like it was a bad question. It had to do with surgery after someone had an MI with no coronary intervention. And that doesn't happen too often, and the recommendations are a little blurred in the ACC/AHA guidelines. So some highlights and some things to take away and to remember for the exam is that elective non-cardiac surgery should be delayed in a variety of settings for a variety of different times based on what the intervention was. So after a balloon angioplasty, it's recommended to delay surgery for only 14 days. After placement of a bare metal stent, it's recommended to wait at least 30 days, at which time your antiplatelet therapy can be held. And after drug-eluting stent placement, it's recommended to wait until at least 6 months. Although if the surgery is urgent, you can consider stopping the dual antiplatelet therapy after 3 to 6 months after placement of a drug-eluting stent. All right, this question had to do with emergency surgical airway and what the most prompt way to do that was. So it's generally understood that the fastest way to obtain surgical airway is through the surgical cricothyrotomy. What this entails is a horizontal incision at the cricothyroid membrane, quick insertion of an ET tube, and then confirmation that the tube is in the trachea with end-tidal CO2. A lot of you chose that the percutaneous needle techniques were the most prompt way, which isn't necessarily wrong with experience, although with relative inexperience, this requires a little bit more equipment and can take a little bit longer to access the airway given the more complex nature of the equipment. All you need for the surgical cricothyrotomy is a very small scalpel, like a 20 blade or 15 or 20 blade, and an endotracheal tube and a finger. All right, so uncuffed endotracheal tubes and leak pressure. This comes up all the time on both the basic and the advanced exam, and it's a tricky topic because we really don't use uncuffed endotracheal tubes very much anymore. They were very once commonly used in pediatric practice because the narrowest part of the airway in a pediatric patient is the glottic opening. So therefore, the balloon theoretically has very little benefit because once the endotracheal tube passes through the glottic opening, it's already past the narrowest portion. A large study was done that essentially showed no greater risk of airway edema or croup when using a cuffed endotracheal tube. And since cuffed endotracheal tubes tend to protect the airway a little bit better, and you don't have to worry about leak pressures, they've generally fallen out of favor. So sizing. When you place an uncuffed endotracheal tube, the first thing you try to do is manually generate a leak and then note at what point that leak was first seen. So if it's easy to generate a leak, meaning under 20 centimeters of water of pressure, the tube is too small. And the problem with that is essentially you still have an unsecured airway and it's hard to give appropriate volumes during the procedure. If the leak isn't generated before you reach 30 centimeters of water, it means that the tube is too big. And the risk there is injury to the tracheal mucosa. So it's best to remove the tube and replace it with a smaller size. All right, another set of guidelines in addition to the AACC-AHA guidelines to review are the neuraxial anesthesia and ASRA guidelines. So this question gave you several different anticoagulants and asked which was wrong, which statement was wrong when placing a neuraxial anesthetic. So with IV heparin, if you're systemically heparinized, you should hold the medicine for at least 4 to 6 hours prior to the procedure, and you're allowed to restart the medicine 1 hour after the procedure. The same is true with sub-Q heparin, but you may restart the medication immediately after the procedure. This can be confusing for some of our residents in the past because as a department we tend to err on the side of caution and wait for at least 1 hour after in order to give sub-Q heparin after we place an epidural, although this is not part of the ASRA guidelines. Coumadin, you should hold the medication for at least 5 days and have a normal INR, so INR testing is required. Normal is considered less than 1.5, and you can restart Coumadin immediately after the procedure. Plavix should be held for 7 days prior to the procedure, and there's no delay in restarting as long as you don't give a loading dose of Plavix. All right, another common question that comes up on the basic exam is detection of venous air embolism. So venous air entrapment can occur when venous openings are above the level of the heart. So the classic example is the sitting craniotomy, when the cranium is open and the surgeon is operating in and around the venous sinuses. When the pressure in the sinuses is lower than the venous pressure, air can be entrained. Other common causes include unprimed uterine and bladder scopes. I've actually seen this in my short career. It was pretty tragic. And also with central line placement and removal. That's why we always tend to put the head down slightly when we both put in and remove central venous lines. So detection, we can detect venous air in several different ways. And this chart over on the right side shows us the sensitivity of the different ways. So echo is the most sensitive. Doppler is also quite sensitive, but is not quite as sensitive as echo. What you hear on Doppler is referred to as a mill wheel murmur. And then our other ways of detecting venous air embolism are less and less sensitive. So pulmonary artery pressures, cardiac output, CVP, and then finally changes in blood pressure and changes in EKG are at the very end, very lowest sensitivity. Okay, so the desflurane vaporizer often will come up on the basic exam just because it's unique when you compare it to the other variable bypass vaporizers. The reason for this is that the partial pressure of desflurane is very, very different than the partial pressures of both sevoflurane and isoflurane. The partial pressure is very close to the atmospheric pressure. So what this means is that desflurane will essentially continuously vaporize until its partial pressure in whatever environment it's in reaches 660. So if that's in a fairly large operating room, it will continue to vaporize until essentially forever. That's also why it vaporizes so much more quickly than the other inhaled anesthetics. That's also why it comes in a special container, because you literally can't open it to the environment or it will almost immediately vaporize. So what happens with this faster vaporization is that more heat is used. So when desflurane vaporizes, it gets very, very cold very, very quickly. And it vaporizes so quickly that if it was in an open environment, it would immediately ice over. Because the temperature would then lower, the desflurane then would vaporize less quickly, and the vaporization, the rate of vaporization, would be extremely variable. So why we have a heated vaporizer is to eliminate the problem of icing over. So this ensures more consistent vaporization of the liquid to the gas phase and creates a constant level of output. This pictures the innards of the desflurane vaporizer, and you can see the heater within the liquid desflurane, and it is arranged a little bit differently than the variable bypass vaporizers. Okay, that's the end. Good job, guys. Please reach out to me with anything as you continue to prepare for this exam. I know you guys are doing great, and I know you can all pass. Nice job.